So I was giving a talk last night, and it's the usual thing. I couldn't get the slides to work. So I was thinking I had to get the help from the back of the room. I was thinking back to the days, and I'm looking at this audience as quite young, but this was an older audience last night. A lot of university staff, and we were all recalling the days when we just turned up in the lecture theatre with our acetates. Remember that? You just switched it on, and you slid this little piece of plastic underneath, and it worked, unless the bulb had gone, and then it was a long repair job. Anyway, the microphone is working. I've got some slides. I'm going to talk for about 25 minutes. And then hopefully, as Helen said, we'll have some time for discussion. So the areas that you work in are very close to my heart. Prevention, as Helen said, is something I'm very committed to in public health. And the wonderful thing about movement and physical activity is in most cases it's free. Not in all, but in most cases. And as Helen said, we are in a difficult financial context. And I think we need to make the case, as I try to, not always successfully, to our decision makers that we can do prevention, whether it be regulation or other things, which actually are not going to cost millions of pounds. So what I'll just tell you before I show the slides is what I'm going to cover. So the title is very generic, and I thought I would talk about all the different sectors that are in this room and how we can work together. So I'm going to give you some examples from first of all, set the context, why the work that you do is so vital, and then talk a little bit about the new research consortium we have in Scotland, Behavioural Research UK, and give you a practical example of how some of the theories and concepts we use in behavioural research can be applied to movement for health. Some of you will be familiar with that, for some of you it will be new. And then many of you in the room have come from our voluntary sector that plays a vital role in prevention. And I'm just going to give a couple of examples from a charity I work with on the board, Diabetes UK. I could have chosen many others. And then finally, try and explain what we're doing in government in my Chief Social Policy Advisor role around a new population health framework for Scotland. So I hope you'll find that interesting. So to kick off, a slide that many of you will be familiar with from the King's Fund that talks about the factors that affect our health from birth right through life, and the different emphasis we need to place on decisions that we can make about what will improve people's health. So the main upstream drivers are social and economic factors. That's the case across the world. But health behaviours also play a major role, and they're constrained by environment, which I'll talk about. And health behaviours have changed through time, often because of forces beyond our control, the activities of industries and others. But the key thing is that we know in relation to prevention, whether you're thinking about behaviours or the physical environment, that supporting individuals and communities to be more active in ways that are appropriate and possible for them really will help address the burden of disease and improve quality of life. Now, there's only 20% of this diagram that is a responsibility of health and social care, but there is much that we need to do in that sector to connect to prevention, whether that be in primary care or beyond. So the current context, the second thing I just want to emphasize is it's very challenging, and that's changed through my life course and for many of you in the room. So up until about 2011, 2012, we were seeing real signs of improvement in Scotland. People could expect, on average, across society to see life expectancy continuing to increase and to also see healthy life expectancy increasing. And from that period, we began to see a decline, a stalling of that improvement in life expectancy and healthy life expectancy, but also a widening of inequalities. And we know that the number of people who are dying early is increasing. People are spending more of their time in ill health, and we're going to be focusing today on movement for health for people with long-term conditions, but also that gap in life expectancy is widening. Now, so other countries are experiencing this as well, but not all. And the main reasons for that decline in the UK are largely due to austerity and the impact on our public services and the income that households get from employment or from the benefit system. That's been the biggest impact on our health. And those are not issues you're going to be talking about today, but the patients, the people, the members of your communities that you support will be experiencing all of those things, and they have been for some years. So that's the kind of inequalities context. The second thing, and I'm going to move on to the more positive evidence shortly, is that the burden of disease in Scotland is increasing. Now, some of you will be very familiar with this work. It came out last year, but there was also a recent update looking in particular at diabetes and a couple of other conditions where some of the numbers are very large. So what we're expecting to see is that the disease burden overall in Scotland will increase by about a fifth, and our population is also projected to decline slightly. Now, if you look at the census that's been recently released, actually we saw a slight increase in population entirely due to migration, inward migration, immigration in Scotland. Our population overall is getting older and we're having fewer children, so it's shrinking. And that means that what we call the dependency ratio, the money that people who are working contribute to taxation in relation to the population who aren't working and need support and care, that balance is shifting and it's very challenging. And so we need to think about that and be realistic about the planning for the future. So the priority is to support older people to continue to live well and healthy lives as long as possible, but actually an even bigger focus needs to be on younger age groups if we're going to keep people healthy for longer, active for longer, and contributing for longer. And we know prevention works, and we can perhaps talk about a few examples. So that's the burden of disease. And then thinking about another issue that will be very familiar to you, and certainly Helen and others have written about this, is the impact on those conditions, largely non-communicable diseases, including mental health, musculoskeletal conditions, that contribute to the fact that we have more people who are inactive in the labour market, and that ill health is one of the main features of that. And of course, the pandemic lay on top of that. So we had all these inequalities before. We're never going to eliminate inequalities. No country has ever done that. You can't eradicate poverty, but you can improve the gap between those who are most and least affluent. And so we've seen an increasing burden, and COVID made that more difficult. And there are more people now who aren't in work since the pandemic than in the period previously. But physical activity has a role to play in this. And I just want to tell you a little bit about a new report that's going to be released later this month. Important work, updated from previous estimates, conducted by Professor Paul Kelly and colleagues. And what they've done is tried to estimate the proportion of deaths or mortality in Scotland that are directly attributable to inactivity. And that really brings that up to date from the, as I say, previous work. So 80% of that is amongst the least active group. And Paul and colleagues, when they looked at that, looked at the level of activity that people were doing, but also a significant proportion was adults reporting less than 30 minutes physical activity per week in 2022. And even a small amount of additional movement or exercise would reduce that burden of disease. So that's a significant portion. So I think I was looking at the figures. I think it's about 63,000 people deaths occur in Scotland each year. But as a proportion of something that's really entirely preventable, that's significant. So these numbers are helpful for our decision makers to just try and estimate the changes that need to be made. And another powerful thing in Paul's report is it's local. There's local data. So you can look across health boards and parts of Scotland and you can make the case for better investment or just support for activity and physical activity in your area. So we often talk about smoking, an area I've done lots of work in as the biggest preventable cause of death, but actually we really need to think about a whole range of risk factors, and that includes physical activity. And then the theme or the issue that you're focusing on in many of your sessions today is about long-term conditions. And that just links to that burden of disease. So many of us will be experiencing one or more long-term conditions throughout our life course. And as we get older, what we call multimorbidity is far more likely. So we need to be thinking about how we support people who are living with more than one condition. And in some age groups, that's the vast majority. So that's the context. So let me move on to give you some, I think, really interesting and practical examples of recent research that emphasize the importance of physical activity and movement for health. And just to start off with, I think, as Helen was saying about social prescribing earlier, the fact that we need to support colleagues in primary care and elsewhere to think about exercise as not just an alternative in some cases to medication, but something that can sit alongside care and treatment. And the Moving from Medicine consensus statement, published in a peer-reviewed journal, I think just a couple of years ago, I think is a powerful reminder of what is possible. So again, I'm nicking Paul's stuff here, but he and colleagues, I think Hamish Reid was the first author. They conducted something looking at the paper that's pretty systematic to me. So they did a rapid literature review to come up with these recommendations. They had discussions with clinicians and patients, and then they did what's called a Delphi study, which is a consensus process that's robust, where you have several discussions about the evidence and then you come together to agree the key statements. So physical activity is safe, even for people with symptoms of multiple long-term conditions. If you look across the literature, the risk of adverse events is very low. But again, those of you caring for people with long-term conditions know that's not how people feel. It's not easy. It's not as easy as telling someone just to move more. And again, we've seen that from other studies. And in my own areas of work, the most powerful thing we can do for behavior change is offer help, offer support, offer advice, not just tell somebody that something they're not doing or they are doing is harmful. Everyone has their own starting point, and then if medical review is needed if symptoms occur. So I think useful paper and I think an important starting point for thinking about interventions. So moving on now just to tell you about the new research consortium that we have, and then I'm going to give you an example about physical activity that links some of the frameworks that we use. So coming out of the pandemic, there's been, I think, an increased interest in behavioral research and behavioral science. Lots of people didn't know what that was. They thought we just nudged people to make, decisions or to sell more stuff. That's not what behavioral research is. So this is a large ESRC-funded consortium. For me, it was very important that we located it in all parts of the UK, in all 4 nations. And these are some of the things that we'd like to achieve over the next 5 years. And one of the differences with this new consortium, Behavioural Research UK, is a few others that I've been fortunate to lead or been involved in. It's largely been academics working with partners outside of universities. In this case, they're in the partnership. They're either funded or they're giving resource in kind, and they're very much working with us. So we have Scottish Government at the table, Public Health Wales, UKHSA, a really interesting company that works with transport networks all across the UK for active travel, Transport Research Lab, and Zinc that works with startups and scale-ups. And then you can see some of the other partners here. So it's a very broad team. So thinking about the kinds of theories and methods that we use, for the next couple of minutes, I just want to tell you about the behavior change wheel and COM-B. So how many people have heard of this? Okay, so it's a good level of knowledge in the room. So if you haven't, it's worth thinking about how this applies to your work, and I'll take you through some of the key concepts in a minute. So the Behavioural Research UK is co-led by Professor Susan Mickey and I. So Susan developed the Behaviour Change Wheel with Robert West and others, and it's a tool for policymakers and decision makers to think about how you identify the different components of behaviour and then how you link that to evidence about the interventions or policies that might be possible. So it gives you all kinds of examples. I'll just use one. So I'm going to talk about capability, opportunity, and motivation in a moment, but I've done a lot of work on incentivization. So I've done studies looking at smoking cessation for pregnant women. It's now been rolled out. Small payments to support women to give up smoking. That's highly effective. That's a behavioral technique. Coercion doesn't work very well, but in some cases, for example, if you have policies that regulate stuff, again, I'll just use some smoking examples. Smoking ban, you're basically saying to people, you can't do this. Slightly coercive. Training, enablement, modeling, environment, restrictions. So that might be saying where you can and can't do things, or limiting the availability of products, education and persuasion. So lots of different elements to this. But what it's built around is COM-B. So there are 3 aspects of this. So I guess if you're not familiar with it, think about times when you've tried to change your behavior, right? We've all been there. We've been there with parenting. Thinking of some recent examples in my own life. We've been there with maybe thinking we'll cut down on alcohol or not drink at all. We've certainly been there with physical activity, with weight loss, lots of different issues. So there's 3 main components to this. So the first one is capability. And I guess the question you ask yourself there, think about a behavior. Is this something that can be achieved in principle? So is it possible for somebody to do it? Now, people might have physical, psychological or other factors in their lives which mean actually that change isn't possible for them because it's not appropriate in their context. So that's capability, and there's 2 aspects to that. The first one is physical. So when we're thinking about movement for health, you're dealing with people with long-term conditions, maybe somebody with rheumatoid arthritis, for example. There's going to be things that are not possible for them. But there's also psychological. So I've done a lot of work on addiction, as I said. So if you're dealing with somebody who's a very heavy drinker, they're alcohol dependent, then psychologically they're not going to be able, and in fact physically, it's not safe for them to attempt complete abstinence right away. So there might be other things to do with psychological and physical capability, which mean that behavior change at that time isn't appropriate for that individual. So that's capability. The second one is motivation. So is there sufficient evidence that that motivation or the motivation needed to change the behavior is there? And this is the way that, sorry, Helen, this is not about all journalists, but when the media portrays behavior, they kind of think it's just about motivation. If we could just motivate people. Some of the discussions I have often, and this is not just with journalists, about childhood obesity. You know, if we could just get children in schools, if we could just teach them to cook, that'd solve the problem, wouldn't it? It doesn't solve the problem. The problem is the environment, is the food environment, but there's many other things. So motivation is important, and it kind of has two main aspects. It's automatic and it's reflective. So in the reflective one, we're thinking about actually, I'm going to plan for this behavior change. But the automatic one may be processes that we feel we can do something, and doesn't necessarily require planning. And then the final one, which is kind of the most important when we think about those inequalities that I described and you're all familiar with across Scotland, is our opportunity. So is there sufficient opportunity for the behavior to occur? And that's social as well as physical. So when we think about movement for health and what people need to be physically active, let's use green space as an example, is there somewhere people can go to be physically active? Or if we think about other health behaviors, I'll go back to the smoking example, the one I know best, back to pregnant women. If your mum smoked, your grandma smoked, and you live in a community where other people who are pregnant are smoking, you're in a social context where actually that behavior change is much more difficult than somewhere else. And I'll give you a practical example. One pregnant woman that I interviewed in one of our studies said, you know, when I'm in the city centre, kind of mid-pregnancy, and I'm at work, I wouldn't go and buy cigarettes. This is some years ago. I wouldn't go and buy cigarettes in a shop in the city centre, because if I'm visibly pregnant, you know, that's really not acceptable. But if I go back to my community where I live, nobody, thinks twice. It's fine. So it's the social opportunity, but there's also physical. And all of those things together, essentially amount to what is possible for behavior change, right? So moving on. Just thinking about how we use that in practice. A really good study, not mine, but one that I wanted to highlight because it's directly relevant to what you're talking about today, was a systematic review of barriers and facilitators for adults living with and beyond cancer. So in my work with Cancer Research UK, looking at the evidence, around 30% of people who are diagnosed with cancer and who are only 30% of people who are going through cancer treatment are physically active at that 150 minutes recommended of moderate or vigorous physical activity per week. So what the authors did very briefly, and do look at the paper if you're interested, was map the findings from their systematic review looking across studies, multiple countries, to the COM-B framework. And this was a practical example to try and support healthcare professionals to think about how if you're supporting somebody living with or beyond cancer, how can you support them to be physically active because of that kind of evidence that Paul and colleagues looked at in that consensus statement, which is pretty clear. So the first one, and I'm not going to go through them all in detail, are capability-related barriers. So people feel tired. I mean, cancer treatment is really tough. They're in pain. They might have treatment-related effects. They may have comorbidities. And then also healthcare providers, short of time, may not have knowledge about what's appropriate physical activity for that patient. There's opportunity. So again, patients are going through a rigorous or demanding treatment regime. They have lack of time, again, lack of information. They may have access issues with facilities, or indeed a financial burden to get from A to B or to be active. Motivation, lack of motivation, and enjoyment and fear of overexertion. But some of the things that really helped cancer patients to be physically active were having experienced that in the past, so feeling they could try again, awareness of the benefits, and also receiving good information about the fact that it was safe, it was possible for them, it wasn't going to affect their treatment. And actually, if you look at some of the evidence, one of the most common things that people talk about when they've been through cancer treatment is just the fatigue, in addition to the other outcomes that they experience. Actually, moderate physical activity in the studies done with cancer patients really helps with fatigue. So that's some of the facilitators. And then opportunity, you can read those there, and motivation. So the paper just sets out a series of practical recommendations for healthcare providers. Second thing I just want to highlight before I move on to the government's work is examples from one of the charities in Movement for Health. There's many others. I chaired an Inequalities Commission for Diabetes UK that reported last year. There's a lot of discussion in that document about inequalities for people with type 1 and type 2 diabetes, particularly racialized communities, but many others, and how in relation to prevention, including physical activity, we need to recognize those opportunity-related barriers and do more to address them. And two examples that John Kinnair from Diabetes Scotland highlighted to me in relation to their work with Movement for Health was excellent work in West Lothian. I won't read this out, but some fantastic work that they're doing there, not only for people who are able to be very physically active, but more importantly for people who have a long-term condition and need additional support. And then finally from Diabetes UK, also the football pans in training intervention. So this is a really robust study that was led by my colleagues Kate Hunt and others, randomized control trials where they worked, some of you will be familiar with. They worked with professional football clubs in Scotland, initially with men, to support men to come into the club, be able to use the facilities and be active. And they've expanded that, in fact, in many countries now, nice export from Scotland, again with professional clubs. And in this example here with Diabetes UK, just looking at using that 13-week program to support people who are living with overweight and obesity, encourage them to use the facilities again and be more physically active. So really robustly evidenced, great intervention, still being developed and rolled out in Scotland. So finally, for the last couple of minutes, just to flag the work that we're doing on a population health framework. So it's quite a while, and I can see colleagues in the room from Public Health Scotland, quite a while since we've had a public health strategy for Scotland or a population health plan, long overdue. So this is something we've been working on for about a year now to set out a 10-year framework. We're doing this with COSLA, with the Directors of Public Health and PHS. We've had lots of workshops, and the plan is to have a national aim, priorities, and approach, building on recent strategic plans. A new physical activity framework that some of you will have heard about is also very well advanced, and that will sit alongside the national plan. The timing of when the physical activity framework will come out versus the national plan isn't confirmed, but again, very well in hand. So I think that's positive. You know, if it was just me, there'd be a lot more in there with some really important policy changes I think that we need to make. But we need to be realistic, and I think there are some really helpful signs in this document that I've seen so far that will help Scotland's health. And this is the process we've been using, lots of different contributions from the system. Many of you, or some of you, will have been invited to some of these discussions because the voluntary sector has played an important role in generating the ideas, and you'll see the timeline along the bottom. So where we are now, we have an early draft. We've got new actions that we're committing to in there, or things that we're in consultation that government's not done anything about. And then we're intending to publish it in the autumn. And the framework, just finally, is around these 4 components that I talked about right at the beginning when you think about those factors that determine our health. So linking with our policies around child poverty, addressing poverty, Scottish Child Payment, devolved social security system, Social Security Scotland, thinking about housing, transport, those wider determinants, places and communities, including anchor institutions in the NHS, local government and community planning partnerships, equitable health and care, and importantly there, that population health, healthy living element. So hopefully you will see some, I think, important developments in the document, including connecting to that physical activity framework, so that we can go back to that slide I showed you at the beginning of the pretty dire situation that we find ourselves in. And even in a challenging context, actually, from my perspective, if we could just get back to a situation where things are not getting worse, and we begin to see some signs of real progress again, you know, then I would be delighted, and I'm optimistic that we can make some progress. So thank you very much, sir, for listening. I put on the final slide just some of the context and contacts for different bits of the work that I'm involved in. I'm looking forward to any questions or discussion. And any difficult questions on physical activity, the experts in the back there can answer them, not me. Thanks.
You could just say your name and where you're from first.
Hi there, my name is Pasna, and I'm from a charity called Weekday Wow Factor. Excuse my croaky voice. Excuse me. Yeah, that was a very interesting presentation. Thank you so much. I just wanted to go back to the slide about projected burden of disease over the next decade. In it, it mentions by age group, largest absolute increases forecast to be in males and females aged between age 65 and 84. And the next bullet point says younger age groups need to be targeted now to mitigate potential burden increase. What about older people? What about mitigating that? I feel, because I work with older people who are largely inactive, who live in areas of deprivation in Glasgow, I feel as if that there needs to be another bullet point to include older people. It's an ageing population as well.
Absolutely. So that the burden of disease increase, you're right. We're largely going to see that in older age groups. And if you look at the full report, there's very important suggestions, recommendations, and acknowledgement of the fact that actually, in the context of multimorbidity, there's much more that we can do with people who've already developed a long-term condition to either improve the outcomes when they're going through treatment, reduce the risk of recurrence or other consequences as a result, or coming on from what they've been through, and also just trying to manage symptoms and improve quality of life, which is what many of you are doing. So I think that's key. What I would argue, though, if you think about how you project forward, and it's up to 2040, that report, if you imagine a river, and we've got people near the bottom of the river who are struggling a bit, they're in the water, and they need that support. And that's largely an older age group with long-term conditions. The people who are upstream, up the river, and haven't yet fallen in or got wet, if we could just do more with primary prevention for those conditions like diabetes, cancer, respiratory disease, cardiovascular disease, we'll benefit ourselves in the longer term. So you're right, it's a great question, and it's absolutely the two of them together.
Sorry, Sebastian Plants. I'm a GP in Dalbeattie and Dumfries and Galloway, and I've been involved in a project where we deliver an education module to healthcare teams, both in primary care and a little bit in secondary care, to improve the quality of the physical activity advice that they give. And I'm coming back to your first slide, I think it was, where you looked at the 20% that health influence. Is that did I pick that up correctly? One of the messages that we put across is that actually the influence that we can have is not just in our clinical setting, our consulting room. We're all members of communities. We all have networks of people out with our work. And my personal experience is that actually the impact you can have out with often is greater than what you do in your consulting room. So it comes down to not just talking the talk, but walking the walk.
Yeah, thanks, Sebastian. I think that's a good point. I was saying to Helen, I was with Kerry Loonan yesterday, who's a deep end GP, and she gets very annoyed when that slide comes up, because it kind of assumes that the NHS can only deal with 20% of the health burden or health problems. And of course, as you rightly point out, that's not the case, because you're contributing to people's lives in general, communities. Helen mentioned social prescribing, but also just dealing with quality of life and improving outcomes for people that are not about delivering a drug or being in a secondary acute setting. So all of these things are interconnected. I mean, the argument would be, and Carrie and Steve Mercer and others have written an excellent report about inequalities in primary care recently, about the workforce and about the need to invest more in that setting so that we can support other settings to relieve some of the pressure. So I think that's great. There's really good randomized control trials, as you probably know, about that type of advice in primary care for different behaviors and conditions. And it's a really good point. So thank you.
Hi, I'm Leslie McPherson. I'm a very mature MRes student at the University of Strathclyde. My personal interest is in people living with long-term conditions but currently don't appear to be listed as long-term conditions in the UK, and that's individuals living with hypermobility and the consequences of that within brain and body. It's a lot of judgment comes around these conditions, specifically weight issues. I myself live with lipedema, so my arms and legs are much larger than they should be for the rest of my body. What is being done within public health to create this recognition of people living with intergenerational conditions like hypermobility? Thank you.
Very good question, and not an area that I'm an expert in at all. But I mean, what I would say, and I'll hand over if there's any other colleagues in the room who want to answer that really important question. I think we need to recognize all conditions that people experience. And if I can just touch on one of the points that you made, not being an expert in that area at all, is the issue around stigma. So I think, again, one of the things we looked at in that report that I highlighted from Diabetes UK, which is about a completely different set of conditions, is the burden that stigma has on people who are living with a range of conditions and is something that prevents them from engaging not just in physical activity, but in lots of things that we would want people to have the opportunity to experience and benefit from in society. So I think we need to recognize a wider group of conditions that are under-researched, under-recognized, under-treated, but also to support people who may feel that as a result of their condition, they're either not getting access to the treatment they need or they're experiencing other people's judgment about that. But as I say, I'm not an expert in that group of conditions at all.
I think this particularly comes into childhood. I mean, my research came from my own personal experiences, and also being a teacher of movement. I teach comprehensive classical Pilates. I've been teaching that for over 20 years. And I'm seeing generations of women still coming through who have had stigma at school, being told they didn't try hard enough, they couldn't get up quickly enough, their run tests weren't fast enough. It seems that there is just a tissue difference, which means there's oxidative stress. You might have children at school who are already being told you can't run fast enough, you need to try harder. That stigma starting young. My current data that I've got is showing that a 28-year-old woman said she's frightened to go into classes for fear of rejection. And I think that's really sad that in all the years that I've been involved in fitness, we've not come forward with that. I think it needs looked at much more clearly.
Yeah, and I think it is, as I say, when you talk to people as you are doing in your research with lived experience, that is exactly what people will say. And I think, we just need to recognize that and try and do more about it. So thank you for the question. It's a kind of strange room, isn't it, in terms of how it's...
Hi there. My name's Amanda, and over at Edinburgh Napier, we run a Masters in Clinical Exercise Physiology. It actually begins in September, and it will be the first in Scotland. Now, the profession itself is brand new in the UK, and we really needed quite a bit of help to integrate our new workforce into the NHS. And, we're doing quite well speaking to our networks, but I just wanted to voice this out here because if there's anyone that could help us further, public health, yourself within government policy, all the people that work with long-term conditions, we're now at this point with this new profession in the UK that can deliver, that quite high standard of, professional support for clinical conditions in exercise. So not a question, but I just wanted to say that out loud.
So let's catch up at the break. It'd be good to learn more about that. And also Margaret Douglas, where's Margaret? Is here from Public Health Scotland, not to put you on the spot, Margaret.
Thanks.
Then there are others in the room. So let's chat about that at the break. But
Thank
you. Appreciate it.
Hi there. Thank you again for your presentation. It was really insightful and really informative. My name's Iona Mackay. I'm the Get Out, Get Active or GOGA Tayside Programme Manager. We've got a very robust evidence base for the benefits of physical activity, both on clinical sites in Tayside and creating that pathway into community-based interventions that we also deliver. It's all low level and accessible and all the things that you've touched on today. With all that evidence that we have, and we're just one programme, and all the wider evidence that we have nationally and internationally, what are your thoughts about actually putting some real investment in all the benefits that we talk about in relation to health and physical activity? Because we all know that it's a good thing, but actually putting that investment there and making it meaningful and sustainable is really what matters.
No, I completely agree with you. If you look at all the evidence we have about how we need to rebalance our spend, we need to be doing, as I said, I think it was to Sebastian, our colleague from primary care there, we need to be focusing more on primary care, but we also need to be focusing on community-based prevention, ensuring that it's adequately resourced and people have access to good quality programs. I mean, I couldn't disagree with that. There are some barriers that I observe in my government role, which are very common, and again, there's a good literature on this. So, people will fight to not have a hospital close. They'll lobby their local politicians, and they'll be very, very upset about that. And it's difficult for politicians often to take their eye away from those kinds of acute or other services that people need and invest in the preventative element. That's the first barrier. The second one is it's often a long-term thing, so they're not going to see the return on investment quickly. I mean, I'm just telling you everything you already know. But I've worked in a number of different countries, and I worked, as Helen said, with intergovernmental organizations like the WHO, and it's just a big challenge. The other thing that's overlying that at the moment is the current context in Scotland, where, as many of you will know, the funding and support for the voluntary sector in particular is in a pretty acute state. But I think it's a fundamental, it's a misjudgment. It's not recognizing that actually, if you take that burden of disease seriously and want to mitigate some of that, then it is exactly the interventions around the food environment, around physical activity, around the other risk factors that we need to address. So if anybody wants to write to their MP or their MSP and argue for some of these things, I think that's how citizens can get involved. And as clinicians and practitioners, we need to keep making the case, as those of us who are working with decision makers will continue to do.
Thank you so much, Professor Linda. My name is Melody, and I'm a Master of Public Health student at University of Glasgow. And my question is related to some of the work that you are currently doing with regards to the framework that's about to come out for the next 10 years. Yeah. As a student, and I'm very familiar with the COMBI because they've ingrained it into our heads now. But so my concern with this, because I'm also very passionate from the preventive side of health, I've always done public health, even from right from Nigeria, where I'm from. And I think some of the things that come to light now when I engage with some of the public health literature and some of the work that you are doing at the moment is kind of my concern for the policy aspect, because like you said, most people believe that, if it's a behavior thing, you should just motivate yourself and get it done. But most times we find that, there's a lot of policies that influence someone's ability to carry out a health behavior that's positive. So I just wanted to ask if you can share a bit about some of the policies, if you've thought of policies for what you want to implement to make people more active, not just the younger generation, but everyone really. And yeah, that's my question. Thank you.
Great. Well, that's kind of segueing into the physical activity framework. So I think that what you're going to see in there is a commitment to some of the things that we know work. So more social prescribing, more advice in primary care, thinking about school, educational, community settings, making sure that not just the Daily Mile. Sorry, I'm not going to say the Daily Mile because it's not about the Daily Mile, but there's good examples like that. So you're going to see some of those things, but also in terms of rehabilitation and support for people with conditions. So some of that will be in there. Okay. In relation to the broader plan, in my own areas, I'm particularly keen that we commit to some regulation and policies that actually deal with some of the harmful commodities that affect people's diet as well, and I think you will see some movement on that. Final thing I would say is absolutely brilliant that you're studying public health. So please stay in the field so you can contribute in the future. Thank you.